I can hear you from Liberia.
I'm obviously doing something wrong. My voice is a bit disruptive, I think. My name is Joy Pumapi, and I'm the chair of the RBM Partnership to End Malaria. But I'm also privileged to be a board member of the Medicines for Malaria Venture. And I'm also executive secretary of the African Leaders Malaria Alliance. There's one of the oldest parasites in the world. Those who know how to date these parasites are saying it is probably about 10,000 years old, evolved in Africa. And right now, 10,000 years later, it has concentrated its illness. After evolution, it spread all over the world. 7,000 years ago, it is recorded in China, far, far away from Africa. But now it is concentrated on the African continent. And it is killing our children. It is impeding our development. It is compromising learning and earning potential of our youth, who are the drivers of our economies. So today, we are going to discuss the threats that make it so difficult for us to eliminate this parasite. We are going to deliberate on the need to break down the barriers and to work together. How are we going to create the synergies? And we are going to explore how collaboration can address the inefficiencies. I'm absolutely delighted that to launch us on this critical journey today, we have with us a keynote from the German government. That is Dr. Hildebrand, Director General of the Department of Global Health, Equality, Opportunity, Digital Technologies, and Food Security. Quite a mouthful. And you can see she is adept at handling complex challenges. So, Dr. Hildebrand, please, it's time for your keynote. How do we unlock all these doors? Thank you.
Ladies and gentlemen, good afternoon in Berlin, Nigeria, or wherever you are. Imagine this. Every minute, somewhere in the world, a child loses its life to malaria. It could be your child. This is not a distant story or nightmare, it's today's reality. Malaria is a prime example of the complexity and of a complex interplay between social, economic, and environmental factors that challenge progress in global health. While the facts are serious, there is hope. Malaria is both preventable and treatable. We have bed nets, diagnostics, medicines, and now vaccines. No one should die from malaria in the 21st century. Fighting malaria requires not only medical breakthroughs, but approaches that strengthen systems, because strong, resilient health systems are the foundation of malaria control. You may ask, what is a strong health system? Sure, it prevents diseases, it provides treatments, but more than that, a strong health system works across health sectors and helps address underlying factors like poverty that determine whether people can live healthy lives. With the arrival of malaria vaccines, we have entered a new era. But for vaccines to reach every child, vaccines must be accessible and production must be reliable. To address this, Germany supports the regional production of vaccines and pharmaceuticals in Africa. Strengthening regional production not only improves access to vaccines, it also strengthens local economies and opens doors for private sector investments. The breakthrough of vaccines should go hand in hand with other measures, because it is the combination of measures that is most successful. I don't know if it's the key to all the questions, but it is really important. For instance, there are many overlaps between malaria prevention, and the control of neglected tropical diseases. Therefore, Germany supports the adaptation of health agendas to the effects of climate change. One example is our support to WHO's special program for research and training in tropical diseases for innovative operational solutions. International cooperation and intersectoral initiatives are key for success in tackling malaria and other poverty-related diseases. Medicines for Malaria Venture is a very successful product development partnership in global health. It has been essential in staying ahead of drug resistance and in bringing forward new anti-malarial medicines, especially for the most vulnerable, that is children and pregnant women. Why is this so critical? Because malaria parasites are constantly evolving. Also, with German support, Medicines for Malaria is contributing to sustained innovation. This is the way to ensure that we always have the next generation of medicines in the pipeline. Germany is also fighting malaria by supporting other very important actors, the Global Fund and Gavi, the Vaccine Alliance. The results speak for themselves. Investing in the Global Fund protects and treats millions of people. In countries supported by the Global Fund, malaria deaths have fallen by more than half since 2002. And since the introduction of the malaria vaccine, child mortality has been reduced by 13%. Ladies and gentlemen, the Global Fund's replenishment this year provides a crucial opportunity. We need strong donor commitments to protect hard-won gain. They are essential to reach the 2030 goal of ending malaria as a public health threat. Our development minister, Alabali Radovan, will announce the German pledge later today. And I call on all of you to also contribute to ambitious pledges for the Global Fund. I hope I made you sufficiently curious to hear what this pledge is going to be, so come and listen. As we need to increase the impact of every dollar spent, we very much welcome the efforts of Gavi and the Global Fund for increased cooperation, and we encourage both to cooperate with other stakeholders as well. Ladies and gentlemen, malaria knows no borders, and neither should our response. Our partnerships have proven that when we pool resources and expertise, we can save lives. Let us continue to do this. Thank you very much.
Thank you so much. And you are going to demonstrate how to actually pool resources and work together. And we are really waiting expectantly for that announcement. But like you, we urge everybody to step up to the plate. In fact, we have had several of the African heads of state and government, committing that they will also step up to the plate, both in terms of contributing to the Global Fund and increasing domestic budget allocation to health. Now, what is the actual burden of malaria? You alluded to it, right? The burden of malaria and the strategies for regional elimination. But we would like WHO to speak a little bit more about this. And you are going to listen to a video right now by Maru and Elkan from WHO. Please.
Excellencies, partners, and participants. From the WHO perspective, the global malaria landscape today is defined by two contrasting realities, one of accelerating success and one of a mounting concern. First, the good news, the elimination track. Between 2000 and 2024, 26 countries successfully interrupted malaria transmission. Since 2007, 20 countries have been officially certified malaria-free by WHO. And for the first time in WHO history, the entire WHO European region is now on the verge of certification, pending Turkey's confirmation in 2026. This is a powerful example for other regions to follow. Those countries succeeded because of one, political commitment and domestic financing, resilient health systems and trusted surveillance, strong community engagement, and reaching high-risk populations. The lesson learned is clear. Malaria elimination is not a mystery of science, it is rather a function of leadership, systems, consistent use of proven tools. Now, the second reality, the high burden trap, especially in Africa. The WHO African region still accounts for over 95% of global malaria cases and deaths. 11 countries in the region account for over 70% of the global burden. Progress has stalled and in some settings reversed with significant upsurges, placing the 2023 Global Technical Strategy targets at a serious risk. In 2023 alone, Africa recorded 249 million cases and 569,000 deaths, more than the combined less than 10,000 tons of all notifiable diseases such as cholera, measles, yellow fever, meningitis, and viral hemorrhagic fevers. Yet, malaria rarely triggers urgency and emergency response. It still is managed as routine illness despite being the leading infectious killer on the continent. Today, high-burden countries face convergence of threats, including insufficient political ownership, malaria being treated as a routine burden rather than an emergency, shrinking external fundings without domestic replacements, escalating humanitarian crisis, displacing millions across 43 endemic countries, most of them being in Africa, weak infrastructure and persistent poverty limiting access to care, rising insecticide resistance and drug resistance, including the PF-13 artemisinin resistance, along with the partner drug tolerance, now confirmed in Rwanda, Uganda, with signals in Ethiopia and Tanzania, spreading faster than innovation pipelines for replacement of treatments. So what must be done? WHO supports dual coordinated strategy. For elimination, countries protect gains, maintain the vigilance, sustain domestic investment, and prevent reintroduction of malaria. For high-burden countries, turn the political declarations into measurable action, enhance self-reliance, increase domestic financing, community and private sector engagement, accelerate mortality reduction in line with the Yaoundé Declaration, treat malaria as an epidemic emergency, not as a routine disease, deploy next-generation tools faster, even in conflict and displacement settings, strengthen systems, not just run the campaigns. In conclusion, while elimination progress outside Africa is a major success, the burden in high transmission countries, particularly in Africa, remains immense and demands sustained international and national commitment. With today's tools and systems, no one should die of malaria. This is not just a technical challenge, it is a test of global health equity. Thank you for your attention.
Thank you so much. Thank you. A test of global health equity. A test to see how much we love the next generation. A test to see whether we are comfortable with losing so many children under the age of 5 years every single day. Now, let's go to the countries. So what is the country and community experience with this parasite and with this scourge that is ravaging our communities? We have with us our first panel for this afternoon, Olivia, Executive Director, Impact Santé Afrique, And we have the Deputy Minister of Health of Liberia. I heard your voice, Honorable Minister, earlier on, and you are welcome. Thank you so much for joining us. We appreciate it. And the Minister of Health of Georgia, you are welcome, sir. And we are so privileged to have two ministers here and an NGO leader who works at community level. So, Olivia, I'm going to start with you. What is the current situation with malaria globally, and who is most impacted in your experience?
Yes, thank you very much. First, I want to thank MMV for including civil society and community affected by malaria in the conversation. So I'm here as Impact Santé Afrique, but I represent more than 1,000 organizations in 43 countries who are all united into a global network called CS4Me, Civil Society for Malaria Elimination Network, organization based in Africa, but also in Asia. So at the moment, we are at a critical time in the malaria fight, and we are actually seriously worrying about the future, and also worrying about our goal, our common goal on eliminating the disease. So right now, we know, we have the evidence, we have the data, we know that we still have many people who are not reaching and accessing malaria services in the most equitable way. We still have women, children, especially in conflict area, refugees, displaced populations, people living with handicaps who are in our countries but still not reaching the services. We know that we have a lot of work to do to ensure that we can reach those populations. We salute the efforts that have been made recently because through advocacy by civil society, now we are actually seeing that in many global malaria strategy, WHO, Global Fund, even PMI and others, and in our national strategic plans, there's now an emphasis on reaching the most vulnerable, identifying who are the most at risk, including gender integration and human rights perspective in malaria. And this is something that was not done before, but now we are at least happy to see that in the strategy. But we need to now move from strategy to actions, and actions to activities and concrete interventions at the community level to translate those words, community engagement, reaching the most vulnerable, into concrete action. And so this is very critical. So for that reason, we work closely with national malaria control programs, and even now with policymakers, parliamentarians, to ensure that if a country is going to organize a national net campaigns or any intervention, that we are focusing on one size does not fit all, that we need differentiated approach based on communities' need and communities where they are. We need to make sure we approach the malaria intervention differently. What works for one community does not necessarily work for another. And that also includes how we communicate about malaria, ensuring that we have the local languages that people can actually understand, ensuring that everything we do is actually based on communities and their need, and not based on global, not just global need, but making sure that at the community level, we address the need of those communities. So just to summarize, we still unfortunately have many communities that are still at risk in our countries, and these communities have different needs, and it's very important that if we're going to eliminate malaria, that we have approach a differentiated manner to engage in those communities and ensuring that they have equal and equitable access to these great tools that we know are working now, but also all the malaria services.
Thank you, Olivia. So it's access. We have innovators. MMV has developed so many medicines, but they are not all reaching the people that they need to reach. The vaccine is now available. It is not yet reaching all the children that it needs to reach. We have the new insecticide, dual insecticide treated nets. They are not yet reaching all the people they need to reach. So, Honorable Deputy Minister, Dr. Jabe, what is the current malaria situation in Liberia? And how has this compared with other disease areas? Are you able to control other disease areas better than malaria? What are the challenges that are inhibiting this access?
I want to say thank you for inviting me to this forum. I'm highly appreciative of being part of this program and to share my thoughts on the insights of malaria in Liberia. Well, as we all know, globally, there is no security if malaria is not controlled. That's the same situation in Liberia. Liberia is endemic for malaria, like all other countries in the sub-Saharan region. For Liberia, we have crucial issues that we need to talk about. And to address those issues, we have to look at it in a different of multifaceted approach, and also to ensure that we have the political commitment. Our situation is such that we have made progress. The prevalence has drastically reduced in Liberia since 2016. And compared to other diseases, we know that malaria is on course, especially with introduction of the vaccines and also in the distribution in insecticide-treated nets. But we do have challenges, and we do need other things to make sure that it is actually more of elimination and more of control and all of that. So in Liberia, we have thought that we need a comprehensive political will and also need to strengthen our donor partnerships, especially so in the absence of international commitment of late. We also need to scale up our innovations. For example, we have done a lot of things, especially to increase the uptake of IPT, especially in pregnant women. Just to lay a basis, Liberia has one of the highest maternal mortalities in the Africa region. And if our women and children, and also just to mention also, we have high child and infant mortality also, neonatal mortality. And malaria, as we know, is one of the major causes of deaths in our country. So if we can also increase our preventive measures and also using different methods of engagement with the community, we know that we can overcome that. For example, we have a strong community health program that have been working and ensuring that IPT increase. Our data show that ANC1, especially IPT1 during the ANC, is very low, and we want to continue that using our community health workers. So for example, partnering with NGOs, we have worked with the malaria MVV Ventures and also rollback malaria to help us improve our uptake of IPT in the country. We talk about one district that was very low on using IPT. That innovation, having community health workers, having the community leaders, having media involved in the distribution and spreading the messages of the importance of prevention of malaria in pregnant women and children, that has helped us. So we continue to look at our partnerships with our partners, especially in the midst of donor funding reduction. We're looking for partnership. We're also talking about we want to sustain the pace. Like I mentioned, we have improved our indicators when it comes to prevention. So we want to sustain that pace of continual investment by partnering other NGOs, local NGOs, especially civil society organizations at the community level. So Liberia, as other countries in the tropical region, we are at a risk of still with malaria, but we are grateful for the malaria vaccines. As of late, as of this week, we are scaling up to 9 counties, and all of the counties will now be covered with malaria vaccination. So we want to be grateful for all of that, but we want to sustain the gains that are being made. Our prevalence have reduced, But the main cause of maternal newborn child mortality in Liberia, one of it can be attributed to malaria, the prevention, the treatment of malaria in pregnancy, and also in neonates. So I just want to make that clear. We are doing a lot in my country, but again, global health is not secure if malaria continues to impact the region of the sub-Saharan region. Thank you.
Thank you. So I'm sure our innovators here will be happy to know that the new technologies work. This is what the minister is saying. And the German government just said that you are supporting local manufacturing of the new commodities. They work. So, Honorable Minister, you have just eliminated malaria. It was announced this year in February. Congratulations. Now, what are the key factors? Just give us one or two key factors that you feel enabled you to eliminate, because we want everybody to eliminate this century.
Hello.
First of all, thank you very much for this opportunity to speak about the success that we have in our country in terms of eliminating malaria. But we fully understand that it's impossible for any country to have success to eliminate malaria and to do not have risks coming from any other country, because it's absolutely impossible. So that's why I think that especially in malaria, it has huge importance. It has crucial importance to have the networking and to conjoin efforts to eliminate in not only in own countries, but elsewhere. Excellencies, distinguished guests, dear partners, thank you to our hosts and the World Health Summit for bringing science, policy, and practice into one room. Georgia's malaria story is at its core a health security story. Malaria has historically been an endemic disease in Georgia, accompanied by higher mortality and considerable economic losses. As a result of comprehensive public health measures implemented during the 20th century, tropical malaria was eliminated in 1954 and vivax malaria in 1970. In the early years following Georgia's independence, starting from 1990, the country faced numerous challenges, including the re-emerging of malaria. To minimize the risks, a presidential decree was enacted in 1997, and since 2001, large-scale anti-epidemic interventions have been implemented under the state surveillance program approved by the government of Georgia. At the initial stage of malaria re-emerging, with support from the Global Fund, the country was provided with anti-malarial medicines, insecticides, and trained personnel. Later, with the assistance of the World Health Organization, Georgia planned and implemented complex public health activities. Since 2012, malaria control operations, including procurement of medicines and insecticides, have been fully funded through the state budget. Since 2012, no indigenous cases of malaria have been registered in Georgia. However, several imported cases continue to be reported annually, mainly originating from countries in Asia and Africa. Through a resilient surveillance system, imported cases are promptly detected, diagnosed, treated, and contained, regardless of the patient's nationality. As a result, no local transmission of malaria has occurred in Georgia since 2013. In 2023, Georgia initiated active preparations to obtain certification as a malaria-free country. At present, the country has a strong understanding of malaria-related risks, including those posed by global warming, intensified migration, and the continued presence of natural vectors. Accordingly, entomological surveillance is being expanded nationwide, while healthcare providers and public health professionals are continuously trained to maintain preparedness. Guidelines, recommendations, and educational materials are regularly updated and implemented. And the sustainability of the National Laboratory Network for Malaria Diagnostics, equipped with molecular testing capacity, remains a key priority for us. In recognition of Georgia's effective public health measures and the assessment of international experts, the World Health Organization officially declared the country malaria-free in January 2025. Georgia will keep investing in these pillars and stands ready to collaborate through WHO platforms and regional partnerships to help others reach and maintain elimination. Our goal is simple: protect every community from preventable disease and strengthen the systems that keep us all safe. Thank you very much.
Thank you, Honorable Minister, and thank you for sharing Georgia's experience, particularly how you came back, how you came back with a stronger fight when there was a resurgence of malaria. That's an important lesson that all of us should learn. I'm now going to give the panelists 1 minute each, because they have all three have been pretty comprehensive in what they shared with us. But just 1 minute each to say what is it that they think has been left out that is actually critical for malaria elimination, just in 1 minute. And I'm going to start with you, Minister Jabe. You are muted, Minister.
No, I'm not.
You are okay now. Thank you. Thank you. You're all right
Okay.
now. Yeah.
Okay. So for Liberia, we have leveraged all of WHO recommended tools. We have insecticide-treated nets. What we haven't done is, which seems very difficult, is into residual spraying and chemo prevention. But we have we are investing in our community health program, and we know that this has worked. But with drugs availability, we know that we can make a difference. And we are also have leverage on the Air Malaria Council, who will enable us to mobilize domestic resources, leveraging the Malaria Council, and with goodwill messages, good funds, and everything provides support for our malaria program. So for us, we have established an Air Malaria Council, and we look forward to them working along with us to mobilize more resources. But again, Liberia is one of those countries that has implementing all of WHO recommended tools. We are now administering malaria vaccines. We are now doing insecticide-treated nets. We are now doing therapies with combination. And so we feel that if, as we learned from Georgia, if we have all of those insecticides killing those mosquitoes that are flying from one area to the other, like he said, we cannot eliminate if we have our neighbors all involved still with malaria cases. So a residual spraying that will have no adverse effect on the community, we feel that with that we can eliminate malaria with the support, the commitment, and to sustain the gains that we have already made. Thank you.
Thank you so much, Honorable Minister. Thank you very much. But before I ask the other two panelists to give their one missing piece, are there any questions from the floor? We'd like to open up for questions. We have, where's the mic? The gentleman in front, I'll not say his name. You'll introduce himself, Rob.
Robert Newman, former director of the Global Malaria Program at WHO, and thanks to all the panelists and Joy for a really nice session. It's more a comment than a question, and Joy, you and I have talked a lot about this over the years. You know, I had an aha moment when I was at WHO, which is we talk a lot about the technical things that we can and should do, and that's important. But my aha moment was that the thing we don't invest enough in is human capital, is the leadership and management skills of the people who are responsible for malaria programs. They're pretty complex. But you take people like me, I'm a pediatrician doctor, you put me in charge of a $100 million malaria program, that's not the skills I've really been given, right? That's not really what I've been trained to do. And so, you know, I'd love to hear more from the panelists about what you think we can do to invest in that human capital. How do we build up the leadership and management skills, not just at central level, but also peripherally in countries, such that we can execute this complex suite of interventions and make sure that we make malaria a thing of the past? Thank you.
Thank you, Rob. Any other questions from the floor? Okay, maybe I should give to the Minister, Georgia, if you can please respond. I mean, you spoke a little bit about all the complex systems you have to put in place. So where did you get the management skills?
Actually, for me personally, it's very complicated to give you exact answer what is the major principle or what is the one top priority that can bring success and all the necessary results, etc. I think the major principle is that we need complexity, complex approaches, and everything that can be useful in fighting against malaria must be included in our tactics. Otherwise, I think it will be impossible to be successful in this respect. So that's why what I wanted to emphasize as one of the most important and general things is that, first of all, strong political will, strong political commitment. Of course, we must understand that in case if we will not finance the medicines, for instance, vaccines and all the necessary tools, etc. In such case, it's much, there are huge expenses of society in general, so that's why I think that strong political will, strong political commitment must be there. Besides what was mentioned here, I think the continuous training, all of the professionals who can have some kind of contact with people and somehow to be successful in early detection of cases. So that's why I think that it has crucial importance to develop the system in terms of training of, for instance, primary healthcare units in this respect, because it is very important to, I would say, to give more information to the doctors, to the nurses, etc., people who are working in primary healthcare, as far as they can have earliest information about the cases. So that's how it works. That's how we can be useful in this respect. And besides, of course, there are many, many important topics. For instance, one of the most important things is the international cooperation. As I mentioned before, actually, none of the countries can be successful in this respect. For instance, Georgia has eliminated malaria. But for us, it's, for instance, we have occupied territory. We, Georgian government, are not able to control the whole territory of Georgia at the moment because of occupation. So huge risks are coming from occupied territories in this respect. So that's why we are trying to communicate with doctors, etc., on occupied territories to give them certain knowledge, trainings, vaccines, medicines by means of Red Cross. And especially I want to tell you that most important partner of us in this respect is WHO, who works with people, with doctors on occupied territories, etc. And besides, our partner countries elsewhere, malaria, so attribute of malaria is that it's impossible to have mitigated risks isolated. It's absolutely impossible. So that's why I think that if we want to have mitigated risks in our countries, not to have re-emerging new outbreaks, etc., in such case, we must invest in supporting each other. I mean, other countries, to finally to have elimination of malaria throughout the world. Otherwise, it will be impossible to have absolutely free from risks systems in our countries. Thank you.
Thank you, Honorable Minister. Thank you so much. Olivia, what is your experience with management? I know that running civil society organizations, management is one of your challenges, but what about actually the health service delivery? What is your experience with management, and how do you think the management challenges could be addressed?
Yes, so I believe that in Africa and in countries, we do have a lot of local expertise that is not well used. I think if we can redesign the way we are operating, especially including integration, because within the Ministry of Health, I think the malaria programs could benefit from local experts that are already in the ministry, who can be great managers, even collaborate with other programs, tuberculosis, HIV, vaccinations. We know that they have excellent people who are going to the same community, in the same area, in the same regions to actually do almost the same thing. So I believe in terms of management, especially in this context, we can really optimize the way we are operating, especially at the community level. And for example, we can include joint supervisions of health centers, joint trainings, ensuring that our very small health centers with very small health staff are not too overwhelmed, having to respond to 10 different programs or with 10 different reports and data. So we need to find a way to integrate everything better, not only for the management, but also at the local level where we have the health facilities and health workers who are also suffering from the burden and on having to report to multiple programs at the same time. And that is actually preventing them to spend the time that we need them to spend on the patients and on communities. So I think if globally we have those hard conversations and see how we can improve the way programs are structured or even funded, nationwide we have to do the same, look at local expertise, and at the community level too, we need to see how to be more efficient and really ensuring that the malaria program's primary role, which is to coordinate efforts of local actors, but also to monitor and evaluate, looking at are we reaching the objective, that they can actually have the time to do this role, which is very important, especially at this time when we're talking about global health security and where we are racing against malaria resistance, where we need to increase our domestic resource mobilizations. We need to be more efficient in terms of management, and that is from the global level all the way down to the community level.
Thank you so much, Olivia. I'm sure you'll all agree with me that this was really an erudite panel. They've shared rich experience with us, so let us give them a hand. And listening to this panel, Honorable Minister, thank you so much for joining us from Liberia. Honorable Minister, thank you for joining us and sharing the experience in Georgia. And Olivia, my younger sister, thank you very much for joining us. Let's give them another hand. So it looks like we now know what the situation is and what the possibilities are. And, I'm beginning to have a lot of hope here that we can eliminate this thing before the middle of the century. It's very exciting. So we have a second panel that is going to be addressing eliminating the structural and institutional barriers, because those are the most complex. So how do we make sure that we bring malaria innovations to market and make elimination a reality? We reach those children that Olivia talked about, the gaps that Minister Jabe spoke about, the experience here that Georgia shared with us. How do we make sure that the structural and institutional barriers are addressed? We have another erudite panel, Dr. Ngashi Ngongo from the Africa CDC. Please join us. And we have the CEO of Medicines for Malaria Venture, Dr. Martin Fisher. Please join us. I think you can choose where you want to go, left or right, which side you want to sit. And then, of course, we have Dr. Michael Makanga, who is also going to join us. And we have Christy. Christy, maybe you can come and join Dr. Makanga here, otherwise he'll be on his own. Thank you so much. So these are the experts. Now I'm going to start with the Africa CDC. Several diseases, Dr. Ngongo, such as guinea worm, have been eliminated in many African countries. We keep hearing of NTDs here and there being eliminated. So it means elimination is not impossible. It can be done. Why do you think malaria is so challenging to eliminate?
Thank you very much, Chair, and also let me just thank the organizers for also bringing Africa CDC into this discussion. Elimination is possible. I think even with malaria in Africa, we know that we have Cabo Verde and Egypt, I think, that have also gotten there. That to confirm that it is possible. But the specific realities of malaria, I think I would like just to bring 4 points here. One is that we need to look at the biological complexity of both the parasite itself and also the vector that's facilitated. I think unlike guinea worms, where you just have a parasite that really develop into humans, and then you just need very good water-based interventions to eliminate it completely. With the malaria parasite, it's a different story. The life cycle is complex. It starts in mosquito, it continues in humans. I think even at that level already, you have so many challenges really for interacting transmission. In addition to that, you have a vector that is really widespread. It is quite resilient. Now even complicated now with the challenges of global warming and climate change that is actually expanding the habitat of the vector. That is one thing. And then the second thing is about the partial effectiveness of the interventions themselves. Just look at, we've been really pushing the ITN for quite some time, I think for many years now. But we knew from the beginning that the effectiveness of those ITN were just around 50%, reduction of cases. Now, that on its own is a problem. I think I would like to convey just one message based on that. Now, we are pushing the vaccines. We know, I think, what we can get as really return on investment. But we know, for example, that the effectiveness of RTS is just about 36 to 40%. I think that on its own is already a challenge. Now, when you bring in the issues of resistance, you are now seeing that you are even further, reducing the effectiveness of those interventions. I think that's why there is no doubt that as we move forward, that issue of resistance and the need for new tools is something that's extremely important for us to talk about. The third issue I wanted to talk about is coverage. Just to convey one message, that with that level of effectiveness, you remember, I think Robert was there when you saw WHO. We were smart at the moment to start talking about universal coverage. The reason is that if you have intervention that is 50% effective, you can't be satisfied with 59% of children that are sleeping underneath. Take 59% of 50%, what does it give you? It's about 30% of children that are protected. Now, no wonder the reason why every year we are seeing the increasing numbers of cases because of that combination, that the low coverage is not acceptable when it comes to malaria. I think with malaria, we need to make it clear that we should be aiming at universal coverage of all the malaria interventions as our standard. And then finally is the issue of resources. I think we live at a time that we've all seen what has happened this year, the decline in financial resources. And this year just came a bit more on the fore. But when you look at the actual situation of Africa, for example, since 2021 up to 2024, we saw already almost 70% of decline, in ODA, which means that as we also think about some of the key challenges, we need to look at the issue of funding for malaria, which then also highlights why the discussion about the replenishment of global fund, I think that we need to take seriously. Thank you.
Thank you so much, Dr. Ngashi. Thank you. So access, coverage, access, reach the hardest to reach and be consistent about it. But Dr. Fisher, we have MMV having really done a lot of innovation in terms of medicines for malaria. But from this therapeutics perspective, what are some of the barriers to malaria innovation? What are some of the main key innovations that are needed to overcome those barriers?
Thanks, Joy. Hi, everybody, and everyone online around the world. And thanks to the organizers. So firstly, I'll say they're not our innovations. We're a partnership organization. It's important to say every single thing we do is in partnership, sometimes with multiple partners. And that's the only way it can be done. So that's one point. And I think in order to the innovations that are needed, we need innovation in leadership. We've covered that a little bit, not solved it. Funding, that's perennial. So I don't have 3 hours, so I think I'll leave that one in the parking lot. We'll continue to discuss it. I'll focus on the topic of medicines innovation. And if we talk about medicines innovation, there's only one challenge we have to overcome. It's the biology of the parasite. So the biology of a parasite means the parasite, we were formed out of the chloroquine resistance crisis. MMB was formed 26 years ago because the child mortality rate went up. The mortality rate, of which 75% were children under 5, doubled to 1.2 million on the world's watch when it wasn't really looking. And we're never going to let that happen again, I hope. And that was why MMB was born. Now, in terms of medicines innovation, I would say we innovate how we use current medicines, and we need to innovate what do we need for the future. The first, current medicines, innovate how we use them, is, I would say, immediate to short term, next 5 years. We have really good drugs still. We have the artemisinin class of drugs. There is partial resistance. That is increasing. We don't see overt large-scale clinical failure yet, but I think history and biology tells us we will. We don't know quite how quickly that'll happen, but it will happen. So what we need to do is protect the medicines we have now. We need to treat them with the utmost care and protect them, not just in an endless stream of pilots, but at scale. We're not quite there yet, but we have some really good strategies. One is multiple first-line therapies, where we can use different combinations of these drugs, but takes the resistance pressure off the combination we'd normally use. And we can also geographically rotate that to take the geographic pressure off individual drugs where they're used. Another is using a triple, combining 3 anti-malarial drugs in one single pill, so they have to be taken together. And so they take the pressure off not only the artemisinin component, but most important, we must take the pressure off the very effective partner drugs that take the pressure off the artemisinin component. An example is lumefantrine, one of the components of Coartem. These immediate diversification strategies we must do now, probably at a far greater scale than we are doing. I think there is the will to do that, but they are expensive and much more expensive than simply relying on Coartem or your existing treatment. But we have to look ahead. That's what we can do now. The next is the future. So 5 to 10 to 15 years, what do we need to stay ahead of the parasite? So we can assume the parasite will become resistant to artemisinin. So how do we think ahead of that? So we at MMV with our partners, we set a very, very high bar for new drugs. The new drugs we discover now are 5 to 8 years from the market. So we have to try and have a crystal ball with our partners around the world and our investigators and clinicians in Africa and understand what they need to look like. So what do they need to look like? These drugs have to have a high barrier of resistance, and we can screen that chemically, preclinically, and also look at it in the clinic. They have to be new mechanisms, brand new ways of working, the next generation after artemisinin. They have to be safe in all populations, including pregnant women, all age groups, and people with comorbidities, other comorbidities apart from malaria. And they have to have, we would say, a unique PK profile so they can be very long acting. And the reason is our vision is if we meet this profile, and we are meeting it, many of our compounds are now progressing through phase 1 and phase 2, we can perhaps aim for 2 really important platform transformations. One would be a single dose cure. So new mechanism of drug or combination of such that could cure malaria with one administration, a supervised administration. Right now it's 3 days for uncomplicated malaria. The second could be, and we're dealing in medicines, and I won't speak to vaccines, but you've seen the success of seasonal malaria chemoprevention. Around 52, 54 million children are treated or administered oral chemopreventative drugs monthly throughout the season. Incredible advance. Efficacy, 75 to 85% estimated, measured in some cases. Imagine if you can give a single injection of a medicine supervised to the child or the school-age child or broader populations at the beginning of the season, and they're completely protected. Again, complementary to vaccines, complementary to nets, but I think we need multiple tools in the toolbox. So that's how we view it, innovating now to protect the treatments we have, and looking ahead to innovate for a very uncertain future, but with really, really high barriers of quality and profile for the products that will be needed.
Thank you so much, Martin. I mean, smart medicines, you know. I'm becoming more and more hopeful and ambitious. Definitely before the middle of the century, we'll have gotten rid of this parasite. Definitely. Now, Dr. Michael Makanga as a EDCTP CEO, you have been instrumental in getting malaria innovations towards licensure and in age-appropriate formulations to underserved populations. So actually make sure that get into the mouths of those babies and into the bodies of those babies. So what are the structural barriers, institutional barriers that make this so difficult, that need to be broken? We're having smart medicines here. We're having barriers, external barriers that we are overcoming. Now, how do we overcome this one? What are they?
Thank you very much indeed. And good day, ladies and gentlemen. The European and Developing Countries Clinical Trials Partnership over the last 20 years has been working with partners in Africa, in Europe, and globally to accelerate the development of medical interventions. And malaria is one of the key areas where we are currently investing around 21% of our global portfolio. And here we pay special attention to driving health equity by addressing major unmet medical needs and underserved populations. And this, as you've rightly said, includes women, newborn and children, rural communities, helping them to accelerate progress towards universal health coverage. And if I may use very tangible examples, that we've contributed to, one of them being the most recent, and that is protecting babies 5 kilograms and under, where very recently, in partnership with MMV and Novartis, we supported the development of Coartem Baby. This is with a new formulation of lumefantrine, making it accessible to these very small babies, recognizing that there may be also undernourished children that are very small. The other area is we recognize that many children actually suffer repeated infections throughout the year. And again, in partnership with MMV and Shinpo in South Korea, we supported the development of Pyramax, which is again on the market. On the side of vaccines, we worked. We've just alluded to RTSS, where you've said that there is maybe the efficacy is relatively low, but we supported the evaluation of RTSS in combination with seasonal malaria chemoprophylaxis, bringing the efficacy to more than 90%, and supported the development of R21 and M-Matrix in partnership with the Jenner Institute in Oxford, and in partnership with the Serum Institute in India, and several African institutions to develop this product, which is now available with an efficacy of more than 75%. And if this is evaluated in an environment of other interventions, we believe that this is going to do even much better. Now, coming to some of the bottlenecks that exist. First is fragmented research to implementation pipeline. You will see that there is support for development of new products in the early stage and in the late stage, but the gaps remain between innovation and deployment of these interventions at scale. And this is where we also have to support bridging that gap and also ensuring that the post-registration studies are supported to evaluate them in the real-life environment where they're going to be implemented in relation to other control interventions. Secondly, the short-term funding and underinvestment in this kind of research, which may constitute the second valley of death. Innovation is often constrained where we have this kind of approach where you have limited funding for a bit of innovation and limited funding for investment. And here, this is where there is need for sustained multi-decade investment in frameworks that tie clear research and development to implementation roadmaps. Secondly, the limited local ownership of research agendas. I know that a number of countries are developing, and we are contributing to the development of local scientific excellence and leadership, but more needs to be invested in this area. For instance, we've been trying to invest more in pediatric researchers that can even diversify the expertise to other disease areas. Now, learning from other disease areas, for example, the HIV community has successfully integrated civil society into product development and policy decisions. And TB programs have shown success in developing all oral regimens and fast tracking of regulatory approval via global trial networks. These kind of things can be implemented on the side of malaria. And allow me to draw learnings from the COVID-19 pandemic period, where we can help to reimagine strategies that accelerate progress towards global malaria elimination. The integration of innovative tools, multi-sectoral cooperation, and sustained political and financial commitment that will be needed to revitalize malaria elimination efforts. And to conclude, to also address the ethics and regulatory bottlenecks. Thank you.
Thank you so much, Dr. Makanga. Now, we understand the challenges of introduction and what needs to be done. But what I love is that all of you have talked about working together, working together, working together. Now, Dr. Christy Marcus is going to, from GHTC, we are facing other challenges that have only been mentioned in passing in terms of funding and sentiments from local populations regarding funding for international health. What do you think we need to do differently, both from the local and international perspective, to get greater buy-in and engagement for malaria elimination? Because all of this that the experts are talking about needs to be funded.
Thank you. Can you hear me? Okay, great.
Yes.
Thank you so much for inviting me, MMV and partners, to this panel. Global Health Technologies Coalition, the coalition that I lead, is an advocacy coalition that's global in membership, but really united around the common purpose of bringing about new technologies, especially in the infectious disease space and the neglected disease space. So whether that's vaccines, therapeutics, diagnostics, that's the area that we work in. And I think we have a unique perspective because much of our work is US advocacy, but then we're also working in the multilateral space. So I'm coming to you today as a civil society voice in this, but I also was with the US government for a number of years, and so have a good sense of how we worked when I was with CDC and with State Department with the civil society community. So I'm really honored to be here talking about this because I've seen it from all sides and never would I have thought that I would be a civil society representative. So really has come full circle. But I mean, malaria elimination is really not just a public health challenge, but it's a financial challenge and it's a political challenge. And we're really dealing with this constricting budget environment that we've been talking about on the stage so far. I mean, even in the title of the World Health Summit, the fragmentation that we're dealing with around the world with respect to how global health is funded. And I think that we really need to make the case differently for why and how we should be investing in global health. And the way that I put it when I'm talking to stakeholders is just quite simply, I feel that we've lost the thread. I feel like some of these diseases in some of the countries, like I live and work in Washington, D.C., like malaria happened so long ago it was in the United States. People don't even realize that sometimes. It's why CDC is based in Atlanta, Georgia, because of malaria. But memories are short. And I think unless you travel or unless you have a family member in the military, you might not recognize that Americans are not somehow immune from malaria. We don't have some sort of super, system, some immunity or something. So memories are short. So I think it's really important to highlight why diseases like malaria are important, why they should be eliminated. And in fact, not to sensationalize the issue, but to make it a bit more relevant to an American context. I mean, we have been letting people know that there was locally acquired malaria in the United States not that long ago, a couple of years ago, in Texas, Maryland, Florida. So in the vein of not letting a good crisis go to waste, we let people know that, hey, with global mobility and with populations migrating and with a warming climate, you can no longer say that this is something that happens somewhere else or far away. Like, we really should be paying more attention. So if the argument that it's just the right thing to do and that we've been, a lot of donors have been working in this space for quite a long time for good reasons, but if we've lost that thread along the way, tying this back to domestic global health security is a very sound argument, because I do think this is something that we are likely to see more and more again. So unfortunately, it's important to highlight that reality and make sure that people are aware of that. Also, we in the United States, there's a lot of changes with the way global health is funded, and some of you and some of the partnerships that have benefited from funding from NIH or maybe from USAID or from CDC. I mean, there's a lot of changes that we're grappling with. But one thing that has happened recently is the launch of this new strategy by the State Department. It's called the America First Global Health Strategy. And in that strategy, it really calls for elimination of malaria, which is great. It's one of the 4 diseases that's really called out in terms of the US priority. So that's good to see. And it talks about reducing incidence, reducing prevalence, a lot of the language that we've seen through the President's Malaria Initiative and other programs. But the way that this strategy talks about working is very different than how the US government has worked before. And maybe we'll see this with other donors and other, funders as well. And so one of the key principles of how the US government will move forward and something to be mindful of as advocates and civil society actors is that one of the ways they're going to move forward is in these like compact agreements or these bilateral agreements. So then I think really anchoring, our malaria work into those bilateral or those, country compacts, whatever they're going to look like, but those are being negotiated now. And the US government has been a huge funder of this. I mean, NIH has funded about 70% of the world's research and development. So I think it's really important to follow along with what's happening in that space. And then in each of these countries where the US will be working and other donors as well, really trying to make sure that local groups are raising the prominence of malaria, that they're discussing what's needed. I think some of the things we've talked about here, the leadership, the healthcare workers, just giving voice to that because it's just so important. That strategy also calls for supporting healthcare workers and also US-led innovation. But if public financing is really being threatened, as well as how we're working with product development partnerships, which are really responsible. So groups like MMV that have been critical in bringing about new innovations for malaria by pulling the different pieces of the community together with shrinking public funding. We really can't afford to not be working in lockstep with each other. So I think really anchoring our messages to the global health security piece of it, to the economic resilience, because we know that there is a significant return on investment that was covered by my colleague earlier. And if the US government wants to focus on US innovation and leadership and other countries want to do that, there's space for that. Great. I think we find ways to encourage that. But in this country compact model and in these bilateral processes, I think it's really important all of us to elevate what's important. Is the manufacturing, the distribution? Is it actually new innovations? And there have been some great innovations. So I think that is really critical. So basically, I think just to sum up, connecting to domestic health security in whatever context that is for you, but that's very effective for how we're messaging this in the United States, at least. Economic stability, making sure that we're tying back those return on investment. There is a lot of data around the return on investment for these innovations. This isn't just a feel-good thing to do, although we should be doing that for that reason, but it actually returns significant, and there's good data on that. I'm happy to share that with anyone if you haven't come across that yet. And then again, that innovation leadership. It's so important to have that innovation leadership. It's so much in biomedical innovation. The science just builds on itself, as you know. And if you eliminate an entire category of mRNA technology or some other technology, you might be eliminating the very next innovation that's going to solve, that's going to give you the vaccine that we were talking about. That's really needed for children, this more seasonal vaccine or whatnot. And so really important that we continue on with innovation. So I think that, bringing this back to the local perspective, that local leadership, engaging with partners and donors in this shared space, domestic financing to show that there already is a lot going towards this, but really bolstering that in-country presence, because I think that's where this elimination battle will really be won.
Thank you so much, Kristen. I'm going to open the floor for questions before we go back to our panelists with our last questions. I'll only go back to them if you don't have questions. Okay, someone at the back there. Please introduce yourself.
Hi, I'm Raghu. I work for J&J in the Netherlands. I had a question related to the funding. How much percentage of the funding goes to the preventative measures of malaria rather than the R&D itself?
That's a good question. Are there any other questions? Yes, please. In front here.
Thank you. Larraitz Ventosa from ANESVAT Foundation. So we've heard at the beginning of the session the link between malaria and NTDs, and in the title there is elimination of poverty-related diseases. There's been mentioned a lot of integration during the session also. So I was wondering if any of the panelists have ongoing or planned initiatives to address this link, or to leverage it to increase the impact of malaria and NTDs programs? Thank you.
Okay. Thank you very much. So I'll go back to the panelists. Please answer whichever of the questions you are comfortable with. I'll start with you. You want to start, Dr. Makanga?
Yes, thank you for raising the question of the integration of diseases. And here, our approach has been more looking at the mega trends in terms of the impact of climate change on infectious diseases that are highly attributable to changes in climate. Here, vector control interventions, when we approach them, we use a more holistic approach in terms of the control of the vectors. And for instance, mosquito control. And also when it comes to waterborne diseases, the approaches in terms of the different interventions that would be put in place to approach these, they cut across neglected tropical diseases and malaria. And what is very surprising is on the second thing is on the digitalization of interventions. We are having a very interesting trend that neglected tropical diseases are now beginning to use more digital technologies to reach the rural remote and urban poor communities that were otherwise very difficult to reach. And the third piece is on diagnostics. AI is revolutionizing the way, for example, parasitic infections are diagnosed, and this we see that in the coming years will help a lot in tapping into resources that have been less invested in as more data is being brought in place. I'll leave it here. Thank you.
Thank you. Dr. Ngashi?
Yes, perhaps just to add another element to the integration on what Michael said. We just completed a survey on the African continent of all the 51 member states to look at the spread of community health workers and how they are allocated to different programs. We have NTDs have used a number of community health workers that were just focused on those vertical diseases in particular. Now, what we are now planning to do, because it was not only NTD, even HIV, I think many of these big programs, endemic programs also done exactly the same, is now to shift the 1 million community health workers we have on the continent that are mainly vertical into polyvalent pool of human resources that can save all the key diseases based on the epidemiology of the population that we are saving, so that we can then leverage all the resources that are there to reach as many people as possible. Also in line with what I was just saying, that for malaria, we should be aiming that no population should be left behind. That's what we are trying to do.
Okay. Martin, do you want to say anything about the balance of investments between research and implementation?
Not really. I will say that we have a swim lane, MMB. We're a research and development and access organization for medicines. We'll spend about 75% of our budget on R&D and about 25 to 30 on access. But we'll try and maintain our partnerships for access around the medicine supply chain. So we try and stay where we have the expertise, and then we'll convene and partner with people who frankly probably have more expertise than us in areas outside of medicines, R&D, and access to build the coalitions or be part of the coalition. So we're never the solution. We're not even the solution in medicines, right? We have to build or convene partnerships or be part of them. And we're certainly not the overall solution in ensuring that communities and populations get the medicines they need. We have to have that humility, but be willing to be part of that solution as one partner. So I can only talk about our funding and how we spend our money, but that's because we are predominantly an R&D organization whose focus is, and you've told us this, Ngashi, as a valued board member, has to be focusing on what we have been asked to deliver for the community and our specific skills, which is the access of medicines.
Thank you. I would like to now go give you. I'm trying to keep time. I happen to be an accountant, so I'm very strict with anything that has a number on it. I apologize for that. So I'm going to give you each 1.5 minutes to answer the final questions that I'm going to ask you. So I'll start with you, Dr. Makanga. You spoke a lot about barriers, that are hindering collaboration, engagement, and and introduction of new technologies. But what would you say is the biggest barrier that is hindering collaboration within and between countries? What is the biggest barrier from your perspective?
Thank you. One thing I'll say two. One is the limited regional coordination mechanisms. There is lack of incentives for cross-border cooperation when it comes to South-South platforms. Now, when you look at the WHO data for 2024, and you see that over 90% of the disease burden and deaths are coming from Sub-Saharan Africa, but less than 10% of the countries actually bear the brunt of this. There is need for more regional cooperation and mechanisms to foster international cooperation and reward joint progress, such as through regional innovation funds or other mechanisms that may come through. Secondly, we have differing national priorities and health system capacities. In this case, when you see the interconnectedness of the diseases, and this is why I say that it is important that policy decisions are also informed by data. I'm one of the advocates of post-registration studies that evaluate interventions in the real-life environment in combination approaches so that one can best show the return on investment when the products are rolled out in the communities and at national health facilities so that the countries can now better prioritize based on real data. Over.
Thank you, Dr. Makanga. Dr. Christie, 1.5 minutes for you. You spoke at length about the role of governments and the role of partners, etc. But just say one strong role that civil society can play in this whole process.
One strong role.
Yes, you talked about, for example, you talked about communication, but how can civil society play a stronger role in ensuring that new malaria technologies move efficiently to the delivery at country level?
Wonderful, thank you. I'll answer within my 1.5 minutes, but I wanted to I don't know if the colleague who asked the question about financing is still here, but I just wanted to comment on that as well. Because it ties to my answer to that very good question, because I think if you're looking at prevention versus innovation, right? So prevention tends to be, yes, we need innovation and prevention as well, but sometimes you could think of that as more of like a program, like an implementation of a program. And that could be something that can be done, and you could develop a strategy and you can do that in 1 year to 3 years or 5 years. Innovation, as we heard earlier, there's a long lead time, 5 to 8 years. That's not something that you can negotiate with partners and you can have an agreement and say, great, we've decided and we're going to move forward. There needs to be this basic level of funding and support for research and development and for innovation so you can even see those innovations. So that's what concerns me about the funding environment, is not that there's not enough funding, because I think that's going to be the case, but that we're also directing it more towards these short-term wins where innovation, we need a longer pipeline and we need understanding that that's what it's going to take. And that ties to my answer to this question, which is that civil society can really play a critical role in keeping the pressure on, keeping people accountable to the commitments that they make, to the promises that they make. If someone has a strategy that they're going to eliminate malaria, but they're working year to year or on a 3-year plan, what about the innovation? What about the research that's required? So I think keeping the pressure on, giving voice, people are listening, people are watching, coming as a coalition, coming with other like-minded partners gives a lot of power and a lot of strength, but there's really no other actor that's going to keep the pressure on the way that civil society actors will.
Thank you, Dr. Christie. Dr. Marshall, I think you talked a lot about working with partners. But what does this actually mean to MMV? And just give an example of how this approach of working in partnerships, equitable partnerships particularly, you feel has enhanced the capacity of MMV.
So as a partnership organization, I'll say again, it's really important. Nothing we do on our own, and things of various levels of intervention, from quite significant to maybe not so big. In terms of equitable partnerships, we pay very close attention to this because we're basically a Geneva-based organization. So it's behoven on us to make sure that our partnerships, even when those partnerships stop, they leave a lasting and sustainable skill or accelerated capability within the region or the communities that they are in. Some areas, if you think about the value chain of R&D, from R to D to regulatory approval to access, along that value chain, I could give you lots of examples. And one shout out, and I'll give you one new example. Firstly, a huge shout out, Michael, to EDCTP, because it has transformed the landscape of clinical development in Africa. Of course, we have to do our trials in malaria endemic countries, but Michael's organization and the convening it brings and a condition of the grants, which is entirely appropriate because you tell us that's a condition, then that makes people focus on meeting it, has brought together incredible momentum in partnerships and clinical research. And it's really coming into, I think, we talked about this earlier, Michael, I think some really big results coming from that. And I think when we talk about these results, this will amplify those partnerships because nothing breeds success greater than success. So I really do feel we got momentum in clinical trials. I will tell you that there is something even more exciting, just as exciting, sorry, Michael, for me. And one thing I think we need to get away from a little bit in public health is this not so neglected disease of pilotitis, where we do pilots here and pilots there and pilots everywhere, and another pilot. And at some point, with a lot of these partnerships, we've got to decide when is it time to go for scale, particularly when there's urgency. I will say that because I think about that a lot, particularly in a lot of our access projects. But what excites me in R&D is one thing that everyone is going to talk about at every single panel, artificial intelligence. But please just stay with me for 1 second. So what we have here in malaria is we have a database of 10 million compounds, very high quality database of anti-malarial compounds. We could not afford to partner with Deep Mirror, which is the Google arm of AI, or Recursion, or these extraordinarily high quality, highly skilled commercial entities looking at the application of AI in drug development. But our currency is this database built with our partners. And I'll give you a really exciting example of where this partnership may catalyze and really accelerate what we'd call truly equitable partnership. So we're working with Deep Mirror, and this is the Nobel Prize winning group in London from Google. And with our database, we're working together with our African partners, and we're building a machine learning tool that, learning from this 10 million compound database, is going to accelerate the medicinal chemistry, the design, the invention of new anti-malarials, and it's going to make them of a much higher quality. I'm very confident of that. And here's the kicker. We're going to make it available open access, like an open access machine learning medicinal chemistry tool for any researcher anywhere in the world, particularly if you're in malaria endemic countries, because we've only had one clinical candidate for an anti-malarial drug go into the clinic from Kelly's team in Cape Town in 2014. I think it's time to have more of those coming out of African research groups and having our first approved and accessible African-invented anti-malarial.
Thank you. Ngashi, your fellow panelists have taken away all your time, but we have just been told that we must stop this pilotitis. It's a more dangerous disease than malaria. So you have just developed a roadmap for malaria elimination for the African continent. What do we need to make that a reality? How do we make sure we do eliminate it? Not by 2063, but before the middle of the century.
Yeah, 2063 is the Africa we want. That's too long, too far from now. A couple of quick things I think that have also come out of this discussion. One is that elimination, everybody knows, is a very ambitious agenda that requires leadership. The problem, that's coming back to what Rob just said, we've always focused on leveraging the top level leadership. But in reality, where things happen, it's not only at the top, it's at the bottom there. I think the major shift is that we'll be now aiming toward building that leadership at all levels so that everywhere, everybody can prioritize malaria elimination as a priority wherever they are. And everyone, wherever they are, they can then ensure that there's accountability for results. Somebody keeps an eye on the performance, and that where there are resources, we know that we can not only count on the external resources, everyone that mobilizes resources to match the way, to walk the talk, also puts local resources or national resources into malaria elimination agenda. That's the shift in leadership that we want to see to move this elimination agenda. The second thing, without repeating what Martin said very, very well, we need new tools. But, the caveat, for us in Africa, we need tools that are made locally. That means, Michael, to your point, supporting then the end-to-end process so that right from the R&D down to the access, it is really Africa-led to also address African problems with African solutions. Number three is that we need to look at differently at systems. It's systems for universal coverage of malaria intervention. That's different. You know, we are no more going with our own community health workers. No, we are looking at the continent to say, if there are 1 million community health workers in Africa today, how do we mobilize that as a resource that can deliver malaria interventions? Secondly, we need the evidence to guide our intervention so that we have really targeted and evidence-based intervention. It means we need in that system strengthening to have very strong surveillance and also all the implementation and research that need to be understanding the barriers as we move forward. So that it's not only program, it's program supported with implementation and research to move forward. And in addition to that comes the issue of the cross-border collaboration, which is extremely important. I think even the Minister of Health of Georgia said it, no one can do it alone. I think that's the system that we like to see. And finally, is when we talk about financing, we've always said that this, we've seen, Joy was my Minister of Health actually. When I was director in the Minister of Health, she was my minister. You know, we always say domestic resources. You know the reality, that there's no single government that has got a really limitless fiscal space, that whatever you come, there's money that's just available. We need to support the elimination agenda by also thinking about innovative financing and also bringing the private sector to also invest in this. It is those four elements that at Africa CDC we are thinking, as you saw the green book that came on health financing in Africa, that we think if we focus on those four things and we do them well, we should be really making some steps toward our elimination agenda. Thank you.
Thank you. So if our panelists can remain here, Dr. Barbara, Chief of Staff at RBM, is going to close the meeting. I think you've got all your elements of a big push. So I'll give you 2 minutes strictly because you're already over time.
Yes. 120 seconds, that makes. So thank you very much. Good evening, Excellencies, distinguished guests, partners. I will make it very short because we only have 120 seconds. So maybe talking on behalf of the RBM Partnership to End Malaria, representing 500 partners, so many are here, and the wise and robust leadership of our board chair here. Just 3 key takeaways maybe from this conversation. One about the countries and the leadership of the countries. We heard it at the beginning from Georgia to Liberia, but we also have plenty of many other examples, Nigeria recently. When the countries are driving, we see change happens and the solutions are here. So that's one very important takeaway. Second takeaway, well, 25 years ago, MMV was created to address a market failure, right? And it showed how partnership, public-private partnership enabled to actually have accessible drugs and treatments for the children and the women and the people we serve. We need to continue on this in this spirit, and we need to use it for a next generation of collaboration. And that leads to the third very big takeaway. We all hear about the evolving global health architecture. We cannot work as we did so far, right? We have to change. And for sure, we need to have much stronger bridges between the private sector from Africa, endemic countries, or everywhere in the world, because we cannot now work like we were doing so far. So the lesson I learned is that from this conversation is that the industry, the medicines industry, medicines innovations really now need to be shaped together from the endemic countries and the rest of the world. And it will actually be a win-win for all, especially the people we serve. And as our chair said it, these all are the elements of the big push against malaria. We all have to do our little push of the big push. And I heard so many pushes around here. So this is very inspiring. And I thank you so much. I didn't do it in the 30 seconds, right?
Thank you so much. I'm told that there's a function at 1800 hours where you can go and drown your not your sorrows, but drown your exhaustion and be ready for tomorrow. So please join the rest of the delegates at 1800 hours.